We thought it would be worthwhile to actually have a bit of a review of the field of mendelian randomisation studies in the lipoprotein space. There's been a lot of activity in this space in the last few years, and thought that it would be certainly it's provocative and it would certainly stimulate some conversation in this room. This slide summarises my disclosures. The most important point is the bottom is that I've been busy and I'm lazy, and thankfully both Borg and Brian Ferentz essentially gave their blessing for me to use their slides. So they've done most of the work with regards to this talk, and I'm simply just the conduit of communication. And I think we really are moving forward in this space with, can it really inform what should be the right targets moving forward, and keeping in mind that many of the therapies that we've used in recent years in clinical trials have really not had the opportunity to have such genetic insights at least inform whether development should be moving forward and how they should be moving forward. And so we have had a lot of problems in the last few years. Karam did refer to my evacetrapib nightmare from earlier this year, and it turns out that people call you all sorts of names when you present negative data for clinical trials. So somebody sent this to me. This is the front cover of an industry journal in April of this year, after we reported that evacetrapib didn't prevent events, and people can be really hurtful. I don't think I'm a loser, and if I'm a loser, and probably everybody else in the room is a lipid loser as well. But here's an introductory tale that is not about lipoproteins, but really sets the scene. So, and this is another one of my nightmares. Secretory phospholipase A2 has been implicated in the pathogenesis of atherosclerotic cardiovascular disease, and there's a range of pathology and biomarker studies that very much support that concept. Verasplidib is an SPLA2 inhibitor, and certainly in phase 2 studies appeared to have a favourable effect on a range of cardiovascular biomarkers, both lipid and inflammatory related. So it kind of seemed to make a lot of sense that it should be tested in a large phase 3 outcome trial, which is what we did. Verasplidib proved not to reduce cardiovascular morbidity and mortality. In fact, it proved to have a 60% increase in myocardial infarction rate, which we reported at AHA a number of years ago. And within a matter of days, I had some snippy Mendelian randomisation person from somewhere send me an email telling me that he had this great Mendelian data showing that SPLA2 wasn't causative, and so if you'd only seen my data, you wouldn't have done the study. And I knew your drug wouldn't work. So here is kind of the world we live in from trying to understand the relationship between risk factors and atherosclerotic disease. We have a range of levels of evidence: epidemiology, genetics, which is certainly proliferating, animal models, mechanistic studies, which are largely cellular studies at the bench, and then ultimately intervention trials. And I think that we would all agree that from the LDL cholesterol perspective, we pretty much meet all of those criteria, and we've seen very favourable lines of evidence very much supporting the causative role of LDL cholesterol in the disease, and the flip side, reducing levels of LDL cholesterol, proving in almost every situation, except maybe the CETP inhibitors, to actually reduce cardiovascular morbidity and mortality. The challenge with many other risk factors is that while there are epidemiology reports almost daily in the journals, the rest of the data is quite variable. For a lot of risk factors, there's no genetic data supporting it. The animal models are a bit iffy. The cellular mechanisms are much more speculative, and we've had a range of failures of clinical trials. And keeping in mind from an anti-atherosclerotic perspective, we've really been waiting since the large statin trials to actually find another class of agents that we think reduces atherosclerotic cardiovascular events. And so the CETP inhibitors have been disappointing to date. There is one that continues on, although our enthusiasm for the likelihood of its success diminishes rapidly with time, and our hope has certainly moved on to the PCSK9 agents. And in parallel to all of that, we've seen a kind of a growing up of the genetic world. Not only has the technology of sequencing really proliferated, the cost has come down, the ability to be able to do high throughput screening at a genetic level has increased, the field has expanded, but along with it has been, I think, the analytical approach to how we deal with the data. So we have bioinformaticians, we've seen very much this emergence of the concept of Mendelian randomisation, and here is a schematic, and I'll show you a different schematic which says a similar thing later on, that very much kind of shows you what the geneticists are really thinking of in terms of what Mendelian randomisation is. So on the left you have the randomised trial that we all know well. On the right you have Mendelian randomisation. So you have a randomisation of clinical interventions on the left. You have essentially a random distribution of alleles on the right. So on the left, in the clinical trial, you will fundamentally randomise somebody to a new intervention compared to essentially what we already do, which usually involves a placebo. On the right, you're really looking at the random distribution of alleles, i.e. the normal allele versus an allele which will either affect, in this case, lipoproteins in a elevated or a reduced fashion. You hope, and this is where the kind of the size of the study becomes very important, that all the confounders are evenly distributed. And in general, we think they largely are, certainly in the clinical trial perspective. And in fact, that underscores the fact that the tier 1 journals don't want you putting p-values for table 1. Because if you actually do a large enough clinical trial and you randomise it, you know, the chances are that all of those confounding risk factors, at least the ones you can look at, should balance out. And the same thinking really exists in terms of the Mendelian randomisation approach. Now, whether there's residual confounding is a different issue. And that is an important point to keep in mind. And then ultimately, you're going to look at cardiovascular event rates. So in a clinical trial, that's actually exactly what our primary endpoint usually is, certainly at phase 3. And then the ability to do large genetic studies will look at cardiovascular event rates and ask the questions, are those alleles that are associated with altered levels of lipoproteins, do they similarly associate with alterations in cardiovascular event rates? And in fact, are they predictable? Can we actually infer causation? I'm not going to mention much about LDL in this talk per se, apart from to say that essentially the genetics lines up very nice. It does exactly, it's very complementary to what the observational studies for LDL cholesterol show, that genetic polymorphisms that associate with either a higher or lower level of LDL cholesterol associate with a predictably higher or lower rate of cardiovascular events. For HDL cholesterol, and that's very different potentially from HDL, but for HDL cholesterol the same cannot be said. We consistently see observation studies showing us an inverse relationship between HDL cholesterol and prospective risk, although we've acknowledged for many years that that is not linear. It is largely driven by higher risk at low levels. But there are no genetic polymorphisms that directly associate with alterations in HDL cholesterol levels that similarly and predictably associate with alterations in cardiovascular risk. And so the Mendelian randomisation view of the world is HDL cholesterol simply isn't a causative factor in atherosclerosis, and why they do a victory dance every time one of our HDL cholesterol raising drugs, quote, fails in a large-scale clinical trial. And so this is kind of the view that if we can perform these large analyses early, the information can potentially play an important role. It doesn't have to be the only decision-making point, and I don't think it should be, but it can play an important role in potentially guiding which pathway you should go down in terms of developing new therapies. And in fact, a number of us were at a global Amgen ad board in Philadelphia a few weeks ago, where they pretty much got up and told everybody that their entire strategy is driven on genetics. They bought Decode the Icelandic company, and they're just running these analyses all the time. And that's how they're going to make their decisions on which therapeutic areas and which therapies they pursue moving forward. So, you know, Mendelian, the genetics for CRP doesn't work. It's very consistent with the fact that a lot of the other lines of evidence for CRP don't work either. So there's really not been a lot of enthusiasm to pursue a strategy of developing a CRP-targeted therapy. Remnant cholesterol, as I'll show you, emerges as a potential new target. HDL cholesterol I've already mentioned. HDL may be a very different thing. And LP-little-a I'll talk about a little bit, but we've clearly had an excellent discussion about that already. So remnants, here you come back to this same slide. Turns out that you have a lot of ticks in those rows, that the epidemiology for remnant cholesterol works, the genetics for remnant cholesterol, and I'll show you some of that data works. Many models from an animal perspective seem to show a relationship. We see very similar findings as we've seen with the LDL experience in terms of cellular mechanisms, and then the question will be, do we have therapies that lower remnant cholesterol that appear to associate with a reduction of risk? And the short answer is right now, yes, we do. But do we have therapies above and beyond the broader atherogenic lowering therapies that we have that more specifically target remnants? Will that associate with a reduction in risk? Again, that's, I think, a very open space in terms of moving forward. So we've heard some reference to Copenhagen already. There's really two large prospective studies that have really generated most of this data. You've got the Copenhagen City Heart Study, which was 15,000 patients. They've been followed for 37 years, and there's no loss to follow-up in terms of data. And then you've got the Copenhagen General Population Study, more than 110,000 patients, individuals in the community who have been followed for at least 10 years. I mean, the ability for data linkage, the ability for meticulous tracking of what's happened to these people has really been extraordinary and has really enabled these investigators to perform the studies they have. So here you see from these studies the relationship between non-fasting triglyceride levels and myocardial infarction. The higher the triglyceride level, the greater the hazard ratio for MI. Here you see the relationship with all-cause mortality. Again, the higher the level, you see that there is a mortality signal that certainly independently associates with high triglyceride levels, particularly once you get up above 3 millimoles per litre. Remnant cholesterol, at least in its crudest fashion, is calculated as total minus LDL minus HDL cholesterol. There's no automated direct assay available yet. I suspect that will soon come, and it will just be a matter of deciding what actually just needs to be kind of captured within that assay. Here's what they're really trying to do with these studies. They're trying to be able to demonstrate that, step one, do we have a relationship that we already know about between a particular lipoprotein and cardiovascular disease risk? Step two, are there genotypes that associate with an alteration in that lipoprotein level? Can you calculate what you think the effect size of that relationship is? Can you exclude, within reason, the likelihood that there's nothing else going on, for use of a better word, any pleiotropic effects? And then finally, if you look at it in very large cohorts, do those same genetic mutations not only associate with an alteration in risk, but to some degree, does that really line up with what you would have expected that between the observation between changes in lipoprotein levels and change in risk? Does that genetic mutation seem to associate with at least that magnitude of alteration in risk? Keeping in mind that obviously, you've had the genetic mutation your entire life, so the area under the curve of the exposure to that alteration in lipid level is going to be substantial. And so that's really what they're trying to do with these studies. And then they kind of bring in much fancier approaches, instrumental variable analysis, really, which hope to really kind of confirm and validate causality. Now, these Danish guys are fascinating. They have only attractive people that work in their labs, and that's a male and female comment. But they do have put photographs of them on all their slides. So you'll see a few of those as we go through here. They what? Yeah, Donald. Yes, thank you. So here is data looking at remnant cholesterol levels. Again, combining both of these Copenhagen cohorts, 57,000 individuals. Here, just simply looking at the relationship between quintiles of remnant cholesterol and HDL cholesterol and the hazard ratio for ischemic heart disease. With increasing quintiles of remnant cholesterol, you ultimately do see an increase in the risk of ischemic heart disease, although you have to get into the upper quintiles for that to actually achieve statistical significance. And as we fairly consistently see in population studies around the world, as you go down in quintiles and HDL cholesterol, your risk increases. But here's what you see if you line up both the observational plasma relationships from those cohorts with the genetic relationships. So for increasing levels of remnant cholesterol, both the observational and the genetic associations both significantly associate with increased risk. And again, keeping in mind that comment I made, that what you really want to see is you want to see the magnitude of the risk be at least as much as you would have expected from observational relationships between a lipoprotein and outcome. And in fact, as I said, it really should ideally be more, given the fact that the area under the curve through life exposure of those lipoproteins should be much longer. And so when you look at this relationship appearing to be much greater than this relationship, I think this is kind of consistent with the story they're trying to tell. If you look at the relationship between remnant cholesterol and HDL cholesterol, again, higher remnant cholesterol, lower HDL cholesterol, you'd expect that from a plasma perspective to be associated with a higher risk, as it is. And again, it's associated with a higher genetic risk, much greater. If you look at HDL cholesterol alone, lower levels of HDL cholesterol associate with increased risk. As I've already shown you, the genetics simply doesn't work. And then finally you have LDL cholesterol, which I've similarly shown you. Higher plasma levels associated with higher risk, higher genetic levels associated with higher risk. Again, the risk appearing to be greater, consistent with the duration of exposure to those levels. It's important in the genetic literature that you have external validation of your findings, so it's not just your cohort in which you see that. Here's data from the cardiogram cohort of 87,000 individuals, and very similar analyses. You see for genetics, for high triglyceride, both unadjusted and when you adjust for both LDL and HDL cholesterol, triglyceride associated genetic mutations associated with higher triglyceride levels, associated with a higher risk for coronary artery disease. HDL cholesterol, perhaps unadjusted in cardiogram, seeming to be potentially associated, but when you start to adjust for LDL cholesterol and triglycerides, you lose that significance. And LDL cholesterol, again, from the cardiogram analysis, both unadjusted and then adjusting for triglyceride and HDL cholesterol levels, both clearly associating with a higher risk for CAD. Now, ApoC3, and we're going to hear more about this from David here later on, has very much emerged as a potential therapeutic target, particularly in the hypertriglyceridemic individuals. In the same issue of the New England Journal were two important genetic reports that looked at the relationship between loss of function mutations in ApoC3 and the risk of ischemic vascular disease from the Copenhagen group, and then from an NIH group looked at the relationship between coronary disease. And so certainly two reports is always better than one. Here you see those reports, the Copenhagen report at the top of the screen, the US report on the bottom of the screen. You see in green the alleles associated with a loss of function of ApoC3 associated significantly with a reduced risk for ischemic vascular events in both of those kind of large cohorts. Lp(a), we've already heard extensively about, and you will have already seen some of this data already. Again, here's the observational data. The higher the Lp(a), the higher the risk of events, and I think it was nicely pointed out during the discussion that the risk really was up at much higher levels from a percentile perspective than what we've been kind of talking about in terms of the 30 milligrams per decilitre. You see similar reports from the emerging risk factor collaboration investigators here, more than 100,000 participants across a large range of studies pulled together, higher Lp(a), albeit really now getting out certainly well in excess of 30 milligrams per decilitre before you see that increased risk. And here you see the instrumental variable analysis which was performed, which was really a much more rigorous test for causality from a genetic perspective, looking at the risk of myocardial infarction for a doubling of lipoprotein(a) levels. So here you see at the top, hazard ratio a little under 1.1, but here you see when you look at the genetics in relation to higher Lp(a) levels, a much higher, greater hazard ratio, again consistent with the idea that the artery wall is exposed to that high Lp(a) for a much longer period of time. Most of the studies have very much focused on this KIV2 genotype that seems to be important. You've seen a number of smallish, a number of individual reports looking at a range of GWAS, largely looking and identifying the KIV2 genotype as SNP as being associated with an increased risk of CAD. We see the genetics start to play out beyond the artery wall, and here's the data for calcific aortic stenosis. When you look at Manhattan plots such as this, you're seeing specific mutations for Lp(a), which are highly statistically significant in terms of their association with vascular calcification and ultimately aortic valve disease. This looks at simply, again, plasma levels in the Copenhagen studies with increasing levels of Lp(a). And again, you have to get above 66 milligrams per decilitre in this situation before you start to see any significant signal of an increasing risk for developing aortic valve stenosis. Well, that was 66%, was it? Oh, that was 66%. Oh, sorry, that was too. Thank you, good catch. So, and if you look here in the genetics, again, you see the observational data here at the top. You see a range of different ways of looking at the genetic data, each associating with an increased risk of aortic stenosis per tenfold increase in Lp(a) levels. So that's kind of been the broad lipoprotein kind of experience in terms of these studies in more recent years. I wanted to finish actually by focusing on what I thought was actually one of the most important reports at the ESC meeting this year by Brian Ferentz, who's given me permission to use his slides. And it really was, and it was presented essentially as a late-breaking trial. It looked at a naturally randomised trial comparing the effect of long-term exposure to both lower LDL cholesterol, lower systolic blood pressure, or both on the risk of cardiovascular disease, keeping in mind that the ACC this year we saw the HOPE-3 data in lower risk individuals suggesting that treatment with a statin lowered their risk, treating their blood pressure did not. And this gives a really unique opportunity to perhaps look at this another kind of way. So again, the same rationale is being provided in terms of Mendelian randomisation and what it potentially has the ability to show us. Mendelian randomisation studies having shown individually that both LDL cholesterol and systolic blood pressure each have both causal and cumulative effects on the risk of cardiovascular disease. And because their effects are cumulative over time, focusing on promoting the combination of both a lower LDL cholesterol and a lower systolic blood pressure may be an effective strategy to prevent cardiovascular disease. However, the causal effect of combined exposure to both of those risk factors is unknown. There are prospective epidemiology studies suggest that the effect may be more than additive, but less than multiplicative. And as I said, the HOPE-3 study, which was a 2x2 factorial randomised trial, suggested that there was a benefit of combined LDL cholesterol and systolic blood pressure lowering. However, it was no greater than just LDL lowering alone with a statin. So the objective of this analysis was to estimate the causal effect of combined exposure to lower LDL cholesterol and lower systolic blood pressure on the risk of cardiovascular events. And now they would use a 2x2 factorial Mendelian randomisation study design, and to estimate the potential clinical benefit of that prevention strategy that focuses on promoting long-term exposure to the combination of a 1 millimole per litre lower LDL cholesterol and a 10 millimetre of mercury lower systolic blood pressure. So to kind of walk through again, here you see, I won't go through that in too much detail, the idea of kind of really the complementary kind of designs of a naturally randomised trial as opposed to a randomised control trial. Both fundamentally are really trying to look at some sort of predictable difference in a biomarker between them. In the randomised control trial of a lipid-lowering agent, with some degree of certainty, we're going to have an idea of what the LDL difference will be between treatment group A and treatment group B. And to a large degree, we can do that with regards to the genetic studies, given the experience that we have there. So the study sample was 102,000 individuals aged between 27 and 100 years of age who'd been enrolled in one of 14 prospective cohort or case control studies. The primary outcome was the first occurrence of coronary death, MI, stroke or coronary revascularisation, a range of secondary and tertiary outcomes, which again, is not different than a randomised control trial. In terms of the randomisation scheme, they calculated genetic scores. For LDL cholesterol, there were 46 polymorphisms that associated primarily with a lower LDL cholesterol at genome-wide level of significance. For systolic blood pressure, there were 33 polymorphisms with associated with lower systolic blood pressure at a genome-wide level of significance. And so the genetic scores, as opposed to individual genetic mutations, were then used as both the instrument of randomisation, but also as the instrument of exposure. And so this really kind of illustrates essentially what they were doing there. So if you start off with the LDL cholesterol score, and you naturally randomise to be above or below the median for the score, then you're either going to have a reference LDL cholesterol or you're going to have a lower LDL cholesterol. And within each of those groups, then you were then going to look at the systolic blood pressure score, again, naturally randomising within each to above the median or below the median for the score. So you were going to end up again with a reference blood pressure, and then in the below median, you would end up in a lower systolic blood pressure. So you're going to end up with 4 groups: reference, lower systolic blood pressure, lower LDL cholesterol, and both being lower. And ultimately, you'd be able to look, at least up until that point in the life course in those individuals, what the lifetime risk of cardiovascular events was. This slide really just shows you that if you wanted their LDL cholesterol to be lower, it was. If you wanted their blood pressure to be lower, it was. Not surprisingly, if you wanted both of them to be lower, they were. Importantly, if you looked at the bottom at kind of other risk factors, other demographics, there didn't appear to be any significant difference between any of those groups, within each group being more than 25,000 individuals. Again, I think large enough studies, you randomise, you take those confounding issues out of the equation. So here you look at the causal and cumulative effect of LDL cholesterol, looking at that alone. So if you have an LDL cholesterol score below the median, here you have a lower risk, odds ratio of 0.78. If you look at it, LDL score for each 1 millimole per litre lower level of LDL cholesterol, in fact, you have an odds ratio of 0.458. And if you compare that to the meta-analyses of the statin trials, for each millimole per litre lower level of LDL cholesterol, we typically are reporting 21-22% lower risk for cardiovascular events. If you look at systolic blood pressure, again, here you see the effect of having just the systolic blood pressure genetic score below the median, and that associated with a 3 millimetre of mercury lower level of systolic blood pressure. You have an odds ratio for cardiovascular events of 0.83. If you try to look at that from the perspective of, well, if your score associates with a 10 millimetre lower level of systolic blood pressure, now you have an odds ratio of 0.55. And in fact, if you compare that to the meta-analyses of blood pressure lowering randomised trials, a similar degree of systolic blood pressure lower level translates to an odds ratio of about 0.8. So again, for both of those factors individually, the genetic score seems to, one, work, and two, not as consistent with everything I've shown you to date, seems to have a higher magnitude of effect. So what happens if we look at the combined effect of both LDL cholesterol and systolic blood pressure? If you look at just the genetic scores, if both scores below the median, you have an odds ratio of 0.54. Here was the LDL cholesterol score below the median. Here was the systolic blood pressure score below the median. But clearly you see that the odds ratio for combining them is much lower than both of the parameters by themselves. Here you see the pictorial display of what you see as the effect of a 1 millimole per litre lower LDL cholesterol and a 10 millimetre per mercury lower systolic blood pressure. The benefits are potentially dramatic and substantive, and they very much reflect the concept of your artery wall and whatever else is driving your cardiovascular events being exposed to substantially lower levels of blood pressure and cholesterol throughout the life course. If you looked at secondary and tertiary outcomes, everything kind of lined up the way you'd expect them to. If you looked at subgroups that were pre-specified for this analysis, again, everything lined up. So there did not appear to be any individuals in whom those associations and relationships were not observed. If you look at the effect of having a 10 millimetre lower systolic blood pressure on the rate of rise of your systolic blood pressure with age, and we know that it increases with age, and the likelihood that you'll develop hypertension, the lower your systolic blood pressure starts, not surprisingly, the slope of the increase in systolic blood pressure over time is going to be much shallower. So your blood pressure is much less likely to go up substantially with time, and that's going to ultimately have an impact in terms of your CV outcome risk, also the likelihood that you'll need therapy, and potentially how many antihypertensive agents you may need. They similarly went on and looked at the risk of diabetes. We know that that's highly topical, particularly from a lipid lowering perspective. Here you see individual score analysis looking at the relationship between having an LDL cholesterol score or a systolic blood pressure score below the median and the odds ratio that you would develop diabetes in this cohort. If you were below the median in terms of LDL cholesterol, you had a higher likelihood that you would develop diabetes. If you had a lower systolic blood pressure score, you had a lower likelihood that you would develop diabetes. If you combined them together and you really looked at that group of having a lower LDL cholesterol and a lower systolic blood pressure, and here looking at the effect size of a millimole per litre lower LDL cholesterol and a 10 millimetre of mercury lower systolic blood pressure, there's no discernible alteration in risk of having diabetes in that cohort. So a huge benefit in terms of much less cardiovascular events and no apparent risk of developing diabetes. And then if you go and externally validate these findings, and these were looking at the cardiogram consortium and the diagram consortium, again, you see similar effects here in terms of the benefits in terms of looking for coronary heart disease risk. Not surprisingly, in this cohort, LDL cholesterol lower, systolic blood pressure being lower, similar odds ratios in terms of protection from coronary heart disease events. If you look at the diagram consortium and you just look at the risk of diabetes, again, this is close to 100,000 individuals in this lower level of LDL cholesterol associating with a higher risk of diabetes, lower level of systolic blood pressure, lower risk of diabetes. So those are, I think, really interesting findings. The limitations of this analysis is that they evaluated the effect of exposure to lower LDL cholesterol and lower systolic blood pressure. They did not look at lowering the levels according to medications. Clearly with these approaches, you cannot evaluate the risk of LDL cholesterol or systolic blood pressure lowering medication-induced side effects, and that's clearly important, as we talked about from the Lp(a) experience. Genetic scores do not identify people who are most likely to benefit from therapeutic lowering, and so further research is needed to identify who are the most vulnerable to LDL cholesterol and systolic blood pressure in order to determine who we think would be who would benefit the most from earlier interventions of lowering either these factors individually or both of them as a strategy, and whether that will help personalise their strategies. So in conclusion, LDL cholesterol and systolic blood pressure were found to have independent, multiplicative and cumulative causal effects on the risk of cardiovascular events. Because their effects are multiplicative and cumulative over time, that long-term exposure to just modestly lower levels of cholesterol and blood pressure has the potential to dramatically reduce the lifetime risk of CV disease. And those observations are still of potential importance even in individuals who have apparently normal cholesterol and blood pressure levels. Cardiovascular events are largely preventable, and the prevention of CVD can be substantially improved and simplified by potentially designing preventive programs that try to promote that long-term exposure, and whether that is an opportunity for these strategies to be involved in, I think is important. I think that was a really important observation at the ESC in the middle of all of the studies about high tech. Here ultimately is still getting to the fundamental importance of preventing the disease from forming in the first place. So in summary, Mendelian randomisation studies have provided important insights into the potential role of lipoproteins in atherosclerotic disease. This may underscore why some therapies work, why some don't, and potentially moving forward to identify the most attractive therapies for developing new agents. And I think this really does present us with a new approach to developing novel approaches to reducing CV risk. Question is how we most optimally use that. On that note, I'll thank you for your attention.